Welcome to CareSmarts on Air, a home care podcast, and I'm Ruby Mehta, VP Sales at CareSmarts. In the lineup of experts of the 2024 Pennsylvania Home Care Conference, next we have Bill Dombi, the President of the National Association of Home Care and Hospice on the panel. Welcome, Bill. How are you?
I'm doing well, Ruby. Thanks for giving me this opportunity.
Thank you. Thank you. You don't need an introduction, but just for our listeners here, with nearly 40 years of experience in healthcare law and policy, Bill has been involved in virtually all legislative and regulatory efforts affecting home care and hospice since 1975. During the conference, Bill, you spoke about every aspect of the home care landscape, be it Medicare, home health, Medicare, hospice, Medicaid, HCBS, private duty, personal care, Medicaid Advantage, and innovation for healthcare at home. So I will let you talk about a lot of that stuff now and then go from there.
Yeah, I think just the outline that you gave of the subject areas is really the central focus that I can offer, that being that the breadth and depth of care in the home continues to expand. That within, the decades of work that I have been involved in care in the home, it's almost, kind of like what we've seen in technology where we have, computers that one time filled a room and now they're in our hands as smartphones with more and more power. Care in the home has done the same, growing to a point where we now have, an ability to pretty much provide all types of care in the home setting that would otherwise be provided in a skilled nursing facility and many times only in a hospital as well. So just an exciting time for healthcare at home in terms of that breadth and that depth. Technology's been a big part of it. We're just hoping, and part of the job that I have is to make sure that payers like Medicare, Medicaid, Medicare Advantage plans, the VA, et cetera, keep up with these advances. Those programs tend to be a bit stodgy, and to modernize them is really what we need at this point to take full advantage of this great system of healthcare at home that we're growing. So I'm open to you. Any questions that you might have that you think that the listeners would find some value in, anything, softballs, hardballs, anything you want to throw at me.
Okay, thank you. Thank you, Bill. I think the first question is, we want to tell our listeners that what specific services are covered by Medicare Home Health. Let's start with that.
Well, interestingly, the Medicare Home Health benefit is not much changed from what it was when it first started in 1965. It is a medicalized, a healthcare focused one rather than a custodial care one. So you have coverage for intermittent skilled nursing care, physical therapy, speech language pathology, occupational therapy, medical social services, home health aid services, and even medical equipment and supplies will come from it. So it's a bundled package of services intended actually to meet the needs of a vast population of Medicare beneficiaries. Some people one time thought it was supposed to be a short-term benefit to restore people's function. That continues to be part of it, but so is longer-term services for people who have chronic illnesses, people who aren't even going to recover, people who might choose, to stay at home as life starts to end for them, but not choosing hospice services. So a very broad, very flexible benefit tied to one other element. The patient has to be what's known as confined to the home, or the short word being homebound. That doesn't mean that they're absolutely unable to leave the home, but it's going to be pretty difficult for them to leave the home, and they're going to need another person or some sort of equipment to do so. So a benefit that I would describe as really well invented back in 1965 that has changed with the times quite successfully. So it's not, comparable to the benefit that Medicaid may offer for home and community-based services, which relies mostly on personal care kinds of supports that many people who are elderly or highly disabled will absolutely need. Much more of a long-term care benefit under the Medicaid program. So, two very important programs in home health care, not the only ones, but two very important ones.
Yeah, I agree. In your career, 40 years almost, Bill, what are the innovations that you have seen in the healthcare industry in general? What are the latest innovations that you're seeing?
You know, I think it's a combination that fits into the high-tech, high-touch part of what home care is. Uh, Innovations, both clinical as well as operational back office kinds of innovations, very much tied to technology in a lot of ways. And I've even had personal experiences with them that I'll start with that one because it just always comes to the front of my brain. Uh, my son needed special healthcare services when he was a toddler, and most of the time the needs were being met in a hospital. He was getting infused various therapies, generally antibiotics and the like. Uh, and we then approached our insurance company, Blue Cross Blue Shield at the time, and said, would you consider trying home infusion therapy? Because there had been some great advances in it. It was not in the benefit package. And so we traded benefits. And the next thing you know, he's getting the drugs administered at home through home infusion therapy with professional staff combined with my wife and myself doing it. And he never went back to the hospital as a result of it. Today, he would never even be allowed to go to the hospital in the first place because it is now not just ubiquitous, it is the state of how that care is going to be delivered. When it comes down to other clinical innovations, we have home chemotherapy, home dialysis going on, but most recently, the things that stand out are remote patient monitoring and virtual visits. And that's actually had two generations. It began back in the late 90s from a number of companies that are no longer even in the business of doing that, like Kodak was one of them. Kodak's not in a lot of business now, but it was getting big into virtual visits. And it didn't work at that time as well as it needed to in terms of even adoption, let alone the technology side of it. But today, you won't find a home health care company or a hospice or many other home care companies that are not engaged in virtual visits and remote patient monitoring, 24/7 monitoring, artificial intelligence connect to it to try to send warning signs when a patient condition might be worsening and needing some attention. So those innovations have brought efficiency and brought depth to the service. And in one other way, you can't always get, say, a clinical specialist in wound care to be available at every home health agency throughout the United States at all times. But through those connections, those virtual connections, you could have a home health agency nurse in the home in person connected with the nurse specialist dealing with highly complex wounds to be able to take care of the patient, including taking the smartphone, putting the camera on the wound, and having a resolution that far exceeds what the human eye seems to be able to see. So some really incredible advances on the technology side to deliver care in the home setting.
Yeah, yeah, it has improved lately. With COVID. Everyone saw the benefit of technology, and especially in this industry, I've seen a lot of technological development happening in the last few years.
Well, and you mentioned COVID, a tragedy, the pandemic killed just millions of people all across the world. The silver lining was a home care related one where people became much more aware of the capabilities, tried to stretch home care and found that it wasn't going to break, taking care of people who couldn't find a bed in the hospital, bringing them home with resources that provided, superb care in a quarantine situation, better than they could get if they were in a hospital, certainly better than in a skilled nursing facility. So as much as we see that tragedy, sometimes opportunity comes from it as well, and this was one of them.
True. Yeah, it is. Now, changing gears from technology a little bit here, Bill, but I think our listeners would really benefit with this. What's your take on the Medicaid Access Final Rule?
There are a lot of good things in that rule, that relate to protections for providing access to care. Medicaid home and community-based services is the long-term care program in the United States. It far surpasses now the nursing home patients population under Medicaid. Spending is greater than that, and that was been a multi-decade battle to get there that included congressional supports, included litigation all the way to the US Supreme Court as well. But Medicaid has always been a program which is underfunding services. Many healthcare sectors face the same issues that we face in HCBS, and one of them is compounded in the Medicaid Access Rule, in that the underfunding has led to compensation to caregivers who do incredible work, keep people at home, keep your loving relatives, in the home setting, many people, and the requirement that the rule end up with compensation levels having 80% of the payment rate spent on compensation to the caregiver is a meritorious goal. We absolutely support higher compensation, but if the rates are underfunding the ability to do so, there's going to be consequences to that. The final rule did have some positives attached to it in terms of improvement. Defining what goes into the compensation calculation was expanded. Defining what gets excluded from the overall calculation as a cost, things like nursing supervision to make sure quality of care is being rendered, doesn't get into the equation as it did before. But it's in many ways, we look at this rule and say great intentions, bad execution. And one of the reasons why I think the administration chose to go down the path was its commitment to helping compensate and show the respect for the caregivers, the direct care workers out there delivering the care. Again, something we support, but at the same time, the administration didn't have the power to increase payment rates, or increase the federal share of payments. The administration had tried, but didn't succeed before Congress to get that added federal support in the mix that's there. So we're concerned that the rule will have an unintended consequence of reducing access to care. Fortunately, there's a 6-year window before compliance deadline comes about, and a lot can happen in that 6-year period of time. We hope that things don't become adversarial as it relates to the policy, but that we have some open-mindedness that occurs relative from the states in increasing payment rates and from the federal government and the Congress to provide some financial support. Because in reality, if the state is paying $20 an hour for the service, $16 an hour is not mathematically possible to provide to that worker and still deliver the care, to train the workers, to pay for the travel time to get to the person's home, to do the billing, to stay compliant with program integrity. So again, a lot of positive. We sometimes indicate that the 80-20 part of it is really going to be not just a challenge, it may be a disaster, but 90% of the access rule otherwise are things that we supported, elements to accountability for the states to make sure that they're setting up delivery systems that actually deliver care, to provide access to care. So this is going to be a challenging time for Medicaid home and community-based services, for providers, for the states, for the patients to get there. We're hoping that at least the rule, leaves one message out there that this is a priority population that needs to have high quality care, accessible to meet their needs. It's kind of hard to fix this after the fact if you don't deliver care to people, who need it at that moment. And that we do see then an advancement of bills like the Better Care, Better Jobs Act, pending before Congress to get some real attention. Bottom line, it's a money matter.
Yeah. Yeah. So Bill, we have been, every conference that I attend and people that I talk to, I hear a lot about workforce crisis, and it's been ongoing. Some agencies I talk to, some providers, they manage their employees really well, and they have strategies in place. But overall, for the industry, what's your what have you seen? What are your best advices? Just shed some light on workforce crisis
Yeah,
management.
I mean, what we've seen is that the cause of the shortage is multidimensional. You can't just point to one shortfall, compensation rates paid by Medicaid, as a full explanation of all of it. And it's not just limited to personal care attendants, it's nursing, therapy services as well. Compensation for all of the employee classes in home care, is a challenge because so much of the care is paid for by way of government programs, Medicare, Medicaid, VA, and so on. And if it comes to private pay, you're dealing with a population that not exactly all deep pocketed. They have a limited amount of money to spend and they stick with their budget. And so they might deprive themselves of the level of care that they may need. So, but compensation, the financing aspect of it is there, but it goes, as I mentioned, beyond that. Safety's come up often as a reason for the shortage in home care. The nurses in particular look at home care and question whether or not it is a safe environment to work in. And home care companies have worked hard to create that safe workplace for people, but it's not like a workplace that they can control because the person's going to someone else's home and in a neighborhood different than where the office might be. And there are steps that are taken on that. But more and more needs to be done. We're working our own end of it to try to create toolkits to help people do that. But we've heard this issue from national surveys of that concern regarding safety of services. On the home care aid side of it, a factor beyond the aspect of compensation is image and respect and opportunity. The image is not something that people necessarily aspire to become a home care aide. Some people do, but it's not really at the level of that kind of positive image, getting the respect that it really does deserve when someone's caring for your loved ones. And so that becomes an aspect of it, along with then opportunities either to stay on that job or opportunities to move up the ladder. Clearly we could find people who started off as a nursing assistant who ended up with a PhD in nursing and running healthcare programs today. But in many cases, it might be viewed as a bit of a dead-end job. So we need to create those kinds of opportunities along with it. When we're looking at the explanations, you can't ignore two other factors. One, the education system. We're losing nurse professors to teach nurses for the next generation. How do we address it on the education sphere? And ultimately, beyond that, do we have enough people in this country to fill the jobs that are out there? Home care aides, for one of them in particular. So we end up having that very politically sensitive issue of immigration and coming into the discussion along the way. So multidimensional and multifaceted remedies that are needed to take care of this. It's not the first shortage we've had, but this one is really, really deep at this point.
Yeah. Yeah. And what other challenges do you see in the current home care system, Bill?
I think there's clearly more opportunities than challenges, and there are clearly challenges that go beyond workforce and financing. But I think the biggest challenge probably that we do have is the modernization of the various programs that are out there that finance healthcare services at home, be they commercial insurance, Medicare, Medicaid, et cetera. But also one other aspect of things is, the healthcare community at large has to take its head outside of the four walls that it's spending most of its time in. Whether they're the administrator of a hospital or physician practices, and seeing, how can things be done in the home setting. For me, we're gaining ground on that day in and day out, but there still is a bit of a bias. It may be physicians make more money if they specialize in things that bring people into hospitals. Hospitals continue to attract, just billions of dollars to build more hospitals on it. But the challenges are there, but I have seen progress, for example, in the technology sphere. healthcare technology companies are focusing their attention on community care even more than they're focusing in on institutional care. So there's an awareness factor that continues to need to be improved. There's a cultural element of seeing care in the home actually as a reward to somebody for contributing so much in their life as compared to seeing going into the hospital. You know, if you have a chance to go in the hospital, you must be special. Now it's special to be in the home setting. But again, I'm not kept up at night on the challenges. You know, what keeps me up at night is all the ideas flowing, not just through my brain, but from others to me and stuff on all of the opportunities that are there. So really, honestly, very bullish on the future of healthcare services at home.
Yeah, well, thank you so much, Bill. That is the wealth of knowledge that you have, and you shared it with our audience, with our listeners today. I want to thank you for giving us this time on your Friday afternoon. And I hope you have a great weekend.
And same to you, Ruby, and thanks again for the opportunity. Very much appreciated.
Thank you so much.